Welcome to our channel. Today, we are going to discuss one of the most important topic from exam point of view, that is, odontogenic keratocyst. We will briefly go through introduction, histopathology, clinical features and radiographic features. Derived from dental lamina. In case of mandible, most cases occur in posterior body or ramus of the mandible. In case of maxilla, however, it is seen most commonly between the cuspids and lateral incisor area. It has a remarkable growth potential, and often leads to significant bone destruction. Mostly lesions occur inside the bone, but, in some cases it may not involve the bone. In which case, it is called as peripheral odontogenic keratocyst. A few key points to consider here. The epithelium is parakeratinized with scales-like arrangements of the cells. The basal cells may be cuboidal or columnar and arranged parallel to each other with palisaded appearance. On the luminal surface of the cyst, a corrugated layer of parakeratin is seen. This is my diagram for odontogenic keratocyst. Kindly read the slide and appreciate the histological features as shown here. In the case of multiple cysts, it is important to rule out navoid basal cell carcinoma. The bifid rib is a term used for the ribs cleaved into two at the sternal end. The bifid ribs and odontogenic keratocyst, when seen together, the patient is likely to have navoid basal cell carcinoma syndrome. Frontal bossing is an unusually prominent forehead. The radiograph shows a distinct lesion, with smooth, or scalloped margins. Thin corticated bone outlines the lesion. If you want more lectures, subscribe to my channel, and press the bell icon. These lectures are made from the contemporary oral pathology textbook. You can suggest topics in the comments section.